morning, everyone. Thank you for being here for our bright and early session. We are going to have 3 talks for you, talking about hyperpigmentation and hypopigmentation. So I'm going to go first with the post-inflammatory, post-operative dyspigmentation session. I'm Patricia Ritchie. This is my co-director for the session, Dr. Wu. And in between our talks, we're going to have Dr. DeGiorgio, who will talk about laser and light-based treatments for melasma. So I spend half my life doing lasers and half my life doing Mohs surgery, so I kind of have a mix of post-surgical but mostly post-laser types of pigmentary issues. So I'm going to go through a few skin of color tips and tricks, and then we'll go through specific procedures and specific disorders. So in general, skin of color, laser and light-based treatments are probably the riskiest procedure that we do, but certainly anytime you're creating inflammation in the skin, in skin of color, you are at risk for dyspigmentation. And I put this in here because obviously it's not a laser or device, but we all consider intralesional triamcinolone to be this sort of benign thing, something that we do a lot of. We do a lot of, higher strength and keloids, but hypomelanosis can occur from that and is quite prominent in skin of color. It can happen weeks to months after the injection. And it's something where the melanocytes are still alive. They're just kind of not being able to synthesize melanin to their full capacity. So the pigmentation does come back, but it can take about a year after discontinuation of the steroid for that to happen. Higher risk of this is if you're using triamcinolone and then if you're using higher concentrations of intralesional steroids. And then post-op, I'm going to spend the rest of the talk on lasers, but just a note here in terms of any skin surgeries that you're doing in skin of color. I will talk to patients prior to the surgery, during the surgery, and after the surgery about sun protection. That is the #1 most important thing, certainly after lasers as well. Keeping the area covered while the spot's healing can help prevent any hyperpigmentation issues. And sunscreen with physical blockers is something that I always counsel about too, especially now the mineral sunscreens have gotten better and better where you're not getting a white cast on darker skin types. Postponing elective procedures until fall and winter can be helpful. And then I talk about cool compresses after procedures to reduce inflammation, and sometimes post-op hydroquinone that you can apply with a cotton-tipped applicator just along a linear surgical site, so you're precisely applying it. So laser hair removal, as we all know, we are targeting melanin in the skin for laser hair removal, and melanin in the hair for laser hair removal, but melanin in the epidermis competes as a chromophore. So with skin types 4 through 6 especially, and sometimes darker skin types 3, you're considering longer wavelengths, longer pulse durations, lower fluences, larger spot sizes, and epidermal cooling is super important in this population. And I would say even patients who are skin type 2 or 3 who are tanned, you can create pigmentary issues if you treat them when they are tan. So dyschromia, these are some examples of cases that I've seen, hyperpigmentation and hypopigmentation. These were treated elsewhere, and I will say where I've seen it the most and kind of the most disfiguring dyspigmentation after laser is treating with IPL for laser hair removal, which obviously is not necessarily a laser, but it's broad-based light treatment. So going into ablative lasers here in dyspigmentation, fully ablative laser is your higher risk. I tend to avoid that in skin types like 4 and up. And then fractionally ablative, slightly less risky, and then non-ablative is our least risky. But again, all of these you can do damage with in skin of color. Fractional resurfacing, in all comers, you can treat pigment textural changes from fully ablative lasers, can be used almost anywhere, and you can combine it with other lasers, which might shorten your downtime. But when you're treating skin of color, again, just thinking about the DEJ, short pulse widths with the ablative lasers, epidermal cooling, and lower density, and I will get into more about this lower density component as well, because that is probably the most key component of your laser settings when you're treating skin of color. In terms of fluences, if you're using a low fluence, your treatment is superficial, you're in the papillary dermis, so you can use higher densities, not necessarily in skin of color, but in all comers. Over 50% is considered dangerous, and over 90%, you're approaching fully ablative territory there, so you really need to only be doing that in areas with thicker skin. I tend to reserve that for rhinophyma is probably where I do that the most. So after fractional ablative lasers, what I found to be the most helpful, and the literature has shown this as well, is reducing post-inflammatory hyperpigmentation with a brief course of topical steroids. So this is a randomized trial, 40 patients, skin type 4, full face fractional ablative lasers with CO2 laser. They did split phase clobetasol BID for 1 to 2 days versus petrolatum, and significant decrease in the PIH from 75 to 40%. Greater intensity of the PIH was found in the areas where the clobetasol was not applied. And this is certainly something that we apply on a daily basis to treatment with the non-ablative lasers as well. So scars, we can break up into hyperpigmented or hypopigmented. The hyperpigmented varieties are melanin, so that's more common. Hydroquinone can work for that, and then if that's ineffective, nanosecond or picosecond lasers. The non-ablative lasers may help with hyperpigmentation a little bit as well, but I will say nothing's really a slam dunk for treating hyperpigmented scars, which is why prevention of the PIH is probably the most important thing. For hemosiderin, nanosecond or picosecond lasers can be helpful. I've done that with actinic purpura too, kind of a similar mechanism. And then for hypopigmented scars, ablative and non-ablative lasers can help a bit. Ablative probably helps a little bit more. And then you can do laser-assisted drug delivery of topical prostaglandin analog, bimatoprost, which has been shown in the literature to be helpful for this. I'm going to go into acne scars a little bit here because most of the literature that I personally have found helpful and apply to my practice comes from the acne scar literature. These are our options for acne scarring, which I won't get into too much because I'm mostly talking about the side effects here. But this is one of the studies that I have found particularly helpful was in treating ice pick scars. They are obviously hard to treat. Lasers are not super helpful in treating them, but TCA can be. Liadol found higher TCA concentrations at shorter intervals were more effective than lower concentrations at longer intervals. And then agarwalidol, so they were looking at a high percentage TSA, 70% TCA in 53 patients with skin type 4 and 5. And they found PIH in 34% of their patients. So overall, these patients were pretty happy in the study, but the 20% that were not cited what made them unhappy with the procedure was development of PIH or lack of improvement. And overall, it was that PIH development that was most bothersome. So going on to our next study here, 100% DSA that in skin types 4 through 5 that Kungur et al. Studied, they had improvement in 73% of their subjects, and they had overall decrease with PIH doing 2 weeks of hydroquinone and 4% and tretinoin pretreatment. So ablative fractional lasers. This was kind of, like I said, I don't necessarily jump to lasers right away for acne scars if they're the deeper variety of ice pick or they're tethered. And if you can't really distend the scars on exam, it's questionable whether lasers will be helpful. And for that, I tend to go more surgical, like punching scars out or doing TCA. But if you can distend the scars and if you're considering lasers, for the fractional ablative lasers, Zhu and Deng did a systematic review looking at 30 studies who had looked at fractional ablative carbon dioxide laser. Response was consistently 25% improvement, and 8 studies had significant improvement after 1 treatment. And you can tell they had 2 to 7 treatment sessions here, so kind of wide variety in treatment frequency. But this was a study that showed pain and post-inflammatory hyperpigmentation with higher density. And you'll see that kind of repeated throughout these studies. Looking at high fluence versus low density, low fluence, high density. So this is a split face trial, and you can see over here to the right on the path images. So it was 10 patients, skin type 4. The higher fluence, low density treatment actually had overall better clinical improvement, and you can see how the necrotic column there is wider and deeper. Additional studies, and I'll go through the details of these on the next few slides, have shown that the PIH is directly proportional to density. So just keeping in mind here that 1, the high fluence, low density was overall better in terms of clinical outcomes, and 2, is also safer in terms of development of PIH. So I alluded to this study on the previous slide, but this was 15 patients, skin type 4 through 6, Mahmoud et al. Looked at. They were randomized to different energies or fluences, if you're considered centimeters squared here. So in 10 millijoules versus 40 millijoules, there was no difference in overall improvement or PIH, but the 40 millijoules was more painful. So that was kind of suggesting that if the energy or your fluence level is not triggering the PIH, what is more likely tied to PIH? And the suspicion is that it was density. And so this is Chan et al.'s study that showed this as well. Retrospective review, 37 Chinese patients. They looked at, again, non-ablative fractional lasers, showing energy and density. Unlike the previous study, both did contribute a bit to PIH, but density was overall more important than the fluence level. And localized PIH was also more noticeable and more prominent in areas with bulk heating and without cooling. So overall, 1, density, and 2, epidermal cooling, super important in treating skin of color patients. So looking at ablative versus non-ablative lasers, this is something I always talk to patients about because your risks of ablative lasers, you really have to take into account in terms of treating acne scars, because you don't necessarily get that much more improvement than you would with a non-ablative laser. So you can tell in this study, I find it to be the most key study for acne scar treatment. It's one that I cite a lot. It was Olga Bashir looked at 26 studies comparing ablative and non-ablative, and you can tell that there's a wider range of improvement in the ablative lasers, getting up to 83% improvement, but it also carried with it longer post-op time of erythema, the 3 to 14 days versus 1 to 3 days, and also had more pain and more PIH. So again, you just really need to balance risks there with potential benefits. Briefly here, because it doesn't necessarily relate to the PIH component, but if your acne scars are severe and skin of color, you can consider microneedling with fractional radiofrequency. It's probably safer. And then several studies have shown efficacy with fractionated delivery of the picosecond 1064 nanometer lasers. So there was a systematic review of 33 articles that looked at microneedling and microneedling RF and in combination with other treatments, and all showed improvement. Overall, I find the key component of this to be that the fractional ablative erbium YAG was better than microneedling for atrophic acne scars. The laser was less painful, but the microneedling had less downtime. So that is going to kind of depend on talking through risks, benefits with your patient. And the laser can often be more expensive as well. Inconclusive data was microneedling alone versus microneedling plus PRP, and microneedling versus non-ablative. But microneedling does have an overall lower risk of PIH compared to laser and light-based devices. So again, something to weigh in your patient population. Picosecond laser, so this was Eric Bernstein looked at 532 and 1064 nanometer picosecond lasers. I would say that the picosecond lasers consistently, the patients notice more improvement than necessarily you would notice as the treating physician or that a photo shows, and you can see that here. So in the 1064 nanometer, 15 out of the 19 subjects were satisfied or very satisfied, but blinded reviewers only put improvement of 1.4 on a scale of 10. And then again here, looking at picosecond lasers in skin types 3 and 4, 20 patients, again with the 1064 nanometer wavelength, 2 passes, and blinded reviewers, 30% average improvement. And so these are A and B are the same patient, and C and D are the same patient. Again, safer in terms of lowering your risk of PIH. So I would say my overall take-home points, I've said it 40 times, but intra-op low density is super, super important in skin of color. Epidermal cooling, super important. Both of those reduce your risk of PIH. Density is more important than depth, and density is what makes your treatment more aggressive. And then post-op and pre-op, sun protection, physical blockers, SPF, counseling your patient about that is the #1 most important thing. Low potency topical steroid for a week or 2, and then you can always do a high potency for a day or 2 after your lasers, and then considering hydroquinone.